Welcome to KJR SummaryCast, audio summaries of peer-reviewed articles published in the Korean Journal of Radiology. Designed to enhance reader convenience and the overall KJR experience, SummaryCast provides conversational audio overviews for time-constrained listeners and mobile-friendly learning. This recording was created using a combination of AI tools with oversight from the KJR editorial team or the article's authors, including necessary edits and corrections. For the most accurate and complete information, we encourage you to also read the original published article.
One of the biggest paradoxes in modern medicine is that we've gotten so good at extending life, we're now facing a whole new set of challenges in how we treat the diseases of aging.
Absolutely. It's a classic case of success creating new problems.
Right, and it raises this really fundamental, almost philosophical question for doctors and patients. When you have an older person, say someone in their late 70s or 80s, and they get a cancer diagnosis, what's the goal? Is it to attack the cancer with the most powerful tool we have, regardless of the toll it takes on their body? Or is it to prioritize their quality of life, even if it means choosing a less aggressive path?
That's the tightrope walk right there, and it's not a theoretical debate. This happens every single day in hospitals around the world. A perfect example of this dilemma is in treating liver cancer.
Specifically, hepatocellular carcinoma, or HCC.
Exactly. It's the most common type of primary liver cancer, and like many cancers, its incidence is increasing in older populations. Now, for a long time, if you had a small, solitary tumor, let's say 3 centimeters or less, the answer was straightforward.
Surgery.
Surgical resection, or SR. Go in, cut the tumor out with a clear margin of healthy tissue around it. It's considered the curative standard. It achieves what the paper calls radical tumor removal. You get the whole thing.
Which sounds great. It's definitive. But we're back to that central problem. We're talking about major abdominal surgery on someone who might be 80 years old with other health issues. Maybe their liver isn't in great shape to begin with because of cirrhosis.
Precisely. And that's the massive downside of the old way. Surgery, as effective as it is, results in a higher rate of post-operative complications. It involves general anesthesia, which carries its own risks in the elderly, things like post-operative cognitive dysfunction or delirium. It damages the liver parenchyma, the functional tissue of the liver. Recovery takes a long time.
And that recovery period isn't just an inconvenience. For an older person, a long, difficult recovery can lead to a permanent decline in function. It's a huge deal. They might never get back to their baseline.
That's the fear. The treatment is a success, but the patient is worse off. Less trauma, a faster physical recovery, those things are incredibly important in this population. So the search has been on for a better way.
A minimally invasive option.
Exactly. And that brings us to the innovation at the heart of the paper we're looking at today from the Korean Journal of Radiology. It's a technique called microwave ablation, or MWA.
Okay, microwave ablation. How does that work? Is it literally what it sounds like?
It's surprisingly close, yeah. It's like having a tiny, incredibly precise microwave oven on the tip of a needle. An interventional radiologist, guided by ultrasound or CT, inserts a thin antenna percutaneously right through the skin and guides it directly into the tumor.
So, no big incision.
No big incision. Once the antenna is in place, they turn on the microwave energy. This causes the water molecules in the cells to vibrate rapidly, which generates intense heat, essentially cooking the tumor from the inside out and destroying the cancer cells.
It's targeted destruction without major surgery. So the question becomes, is it as good? How do you even begin to compare something like that to the gold standard of surgical resection?
That is the million-dollar question, and it's what these researchers set out to answer. It's really tricky because you can't just look at a bunch of patients who got MWA and a bunch who got surgery and compare their outcomes. The groups are often fundamentally different from the start.
What do you mean?
Well, think about it. Who is more likely to be offered a minimally invasive procedure like MWA instead of surgery? Often, it's the older, sicker patients, the ones who are considered too high risk for a major operation in the first place.
Right. So if you just compared them directly, the MWA group would probably look worse, but not because the procedure is inferior, but because the patients were less healthy to begin with.
Exactly. It's a classic confounding bias. It's not an apples-to-apples comparison. So the researchers had to get clever. They started with a large group of 319 patients over the age of 65 with small HCCs. 108 had received MWA and 211 had gotten surgery. And to solve that bias problem, they used a very powerful statistical method called propensity score matching, or PSM.
Propensity score matching, what does that do?
It's a way to create a fair comparison from observational data. In simple terms, for each patient in the MWA group, the algorithm scours the much larger surgery group to find a statistical twin, another patient who is virtually identical across a whole range of important characteristics. We're talking age, sex, liver function, cause of the liver disease, tumor size, platelet counts, you name it. They matched on dozens of variables.
So it's like a computer-based matchmaking service to find the perfect comparison patient, creating two groups that are as similar as possible in every way except for the one thing you want to study: the treatment they received.
Precisely. After this matching process, they were left with two perfectly balanced groups, 80 patients who had MWA and 80 patients who had surgery. It's the closest you can get to the rigor of a randomized control trial using retrospective data.
Okay, so now they have their fair fight. Two matched groups of 80. What were they measuring? What were the key outcomes they were looking for?
They looked at the big picture and the nitty-gritty. The main things were the long-term survival outcomes. First, overall survival, or OS. Pretty straightforward, how long patients lived after treatment. Second, disease-free survival, or DFS, how long they lived without the cancer coming back anywhere in their body.
Okay, survival and recurrence.
Then they looked at something more specific, local tumor progression, or LTP. That's when the cancer grows back right at the original site of treatment.
So at the surgical margin or within the ablation zone.
Exactly. And finally, they looked at the immediate-term stuff that really matters for quality of life. The rate of complications, how long the operation took, how much blood was lost, and how long patients had to stay in the hospital afterward.
A really comprehensive comparison. So let's get to it. What did they find? Let's start with the big one, survival.
This is the first major finding, and it's pretty stunning. When they looked at the 1-year, 3-year, and 5-year overall survival rates, there was no statistically significant difference between the two groups.
Wait, say that again? The minimally invasive microwave procedure had essentially the same long-term survival as major open liver surgery?
That's what the data showed. After 5 years, the overall survival rate was 55.4% in the MWA group versus 64.8% in the surgery group. Statistically, the difference wasn't significant. The hazard ratio was 1.06, which means the risk of death was virtually identical between the two approaches.
That is a huge finding, because the entire rationale for putting an elderly patient through major surgery is the belief that it offers the best chance at long-term survival. This paper suggests that might not be true.
It really challenges that dogma, and it gets better. They saw the exact same pattern for disease-free survival. After 5 years, the DFS rate was 26.4% for MWA and 38.0% for surgery. Again, while the number for surgery looks a bit better, the difference was not statistically significant. No clear winner on keeping the cancer away long-term.
Okay, so from 30,000 feet in terms of living or dying, or the cancer coming back somewhere, the two treatments are a wash, but there has to be a catch. It can't be that MWA is just as good in every single metric. There's always a trade-off in medicine.
You are absolutely right. And the trade-off here comes down to that other metric we mentioned, local tumor progression, or LTP.
The cancer coming back at the original spot.
Correct. In that specific outcome, surgery was clearly better. The MWA group had a significantly higher rate of local tumor progression. After 5 years, the cumulative LTP rate was 22.2% for the MWA patients, compared to only 10.9% for the surgery patients.
So more than double the rate of local recurrence with MWA. Why is that? What's the thinking there?
It comes down to the fundamental difference between the techniques. With surgery, a pathologist can examine the removed tissue under the microscope and confirm that the surgeon achieved negative margins, that there's a clear border of healthy tissue all the way around the tumor. You have physical proof.
you know you got it all.
Right. With ablation, it's a bit more of an art guided by science. The radiologist is aiming to create an ablation zone that's bigger than the tumor to create a thermal safety margin, but you can't be 100% certain you've zapped every single microscopic cancer cell at the very edge. As the paper says, MWA is incapable of achieving as sufficient a safe margin as the R0 resection in SR.
Okay, that makes perfect sense. So with MWA, you accept a higher risk that you might have to go back and treat that same spot again down the line.
That's the trade-off on the efficacy side. But then you have to weigh that against the other side of the coin, the immediate impact on the patient.
The safety, the recovery, the complications. What did the numbers show there?
This is where the story completely flips, and it's the second wow moment of the paper. Let's start with the overall rate of post-operative complications.
Okay.
In the surgical resection group, the complication rate was 97.5%.
97.5%. You mean basically every single person who had surgery had some kind of complication?
That's what the data says. Now, to be clear, most of these were minor Clavian Dindo grade 1 or 2 complications, but still, 97.5% experienced something. In the MWA group, that number was 52.5%.
So the complication rate was nearly cut in half? That is a staggering difference.
It's a massive difference. And when you drill down into specific complications, the gap widens. Postoperative fever, 33.8% with surgery, 7.5% with MWA. Hypoproteinemia, low protein in the blood, 21.3% with surgery, only 3.8% with MWA. The need for a blood transfusion?
Let me guess.
18.8% for surgery patients, only 2.5% for MWA patients.
Oof, those numbers speak for themselves. And the big one for patients and hospitals, post-operative hospital stay, I have to assume that was shorter with MWA.
Dramatically shorter. The median hospital stay for a patient after surgery was 6 days. For an MWA patient, it was 3 days.
Half the time. You go in, have the procedure, and you're potentially home in half the time with half the risk of complications. That's not a small thing.
It's a game changer for this patient population, and we haven't even mentioned the procedure itself. The median operative time for surgery was 163 minutes. For MWA, it was 30 minutes.
2.5 hours under general anesthesia versus half an hour with conscious sedation. That alone is a huge reduction in physiological stress for an older person.
And blood loss, this one is also striking. The median intraoperative blood loss for the surgical group was 200 milliliters. For MWA group, it was 15 milliliters.
15? Like a blood sample, compared to almost a cup of coffee's worth for surgery.
It's a different world entirely in terms of how invasive and traumatic the procedure is for the body.
So let's try to tie this all together. If you're a clinician, a radiologist, a surgeon, an oncologist sitting down with an 82-year-old patient who has a new 2.5 centimeter liver tumor, what does this study tell you? How does it change the conversation?
It fundamentally changes the conversation from a monologue to a dialogue. Before, the default might have been, surgery is the gold standard, it gives you the best chance. We strongly recommend it. Now, you have robust evidence to present a true choice.
You can lay out the trade-offs.
Exactly. You can say, look, we have 2 excellent options. Option A is surgery. It gives us the lowest possible chance of the tumor coming back in this exact spot, but it's a major operation. You'll be in the hospital for about a week, and you have a very high chance of experiencing some complications during recovery.
Option B is microwave ablation. You'll be in and out of the hospital in about 3 days with a much lower risk of complications and a much easier recovery. The long-term survival appears to be the same as surgery. The trade-off is that there is a higher chance, maybe around 22% over 5 years, that we might need to retreat the same spot again if some cancer cells survive.
Precisely. And for many older patients and their families, that trade-off is going to seem incredibly reasonable. They might very well choose a higher quality of life and a faster recovery now, accepting the risk that they might need another minimally invasive procedure later.
It puts the power back in the patient's hands based on what they value most. And it really elevates MWA from being just an option for people unfit for surgery to being a legitimate first-line contender for all older patients with small tumors.
It strengthens the evidence base. Just as the authors say, it makes MWA an alternative curative treatment, not just a palliative or bridging therapy.
All this sounds incredibly promising for MWA, but this is where I always get skeptical. This is one study. There must be limitations. There has to be some caveats here. What did the authors acknowledge as the weaknesses?
They were very clear on this, which is the hallmark of good research. First, and this is the big one, it's a retrospective study. They are looking back at data that was already collected. Even with a sophisticated tool like propensity score matching, you can't eliminate every single potential hidden bias. You can't control for all the unknown unknowns.
Right. It's not a randomized controlled trial, which is the true gold standard, where you flip coin to decide who gets which treatment. That's the only way to truly eliminate selection bias.
Correct. Second, and this is crucial for procedural study, it's a single-center study. The success of MWA is highly, highly dependent on the skill and experience of the interventional radiologist performing it. The team at this hospital in Shandong has clearly done a lot of these procedures and is very good at it.
So you're saying you can't necessarily expect to walk into any hospital in the world and get these exact same results.
Operator dependency is a huge factor.
A huge factor. The utility of these findings needs to be validated at other centers to see if they hold up. Third, there's the issue of the disease etiology. In this patient cohort, the predominant cause of HCC was chronic hepatitis B virus infection.
And in other parts of the world, like North America or Europe, the drivers are different.
Much different. It's more commonly hepatitis C or alcohol-related liver disease or non-alcoholic fatty liver disease. The underlying biology of the liver and the cancer might be different, so you have to be cautious about applying these results to a Western population without more research.
All very fair points. So we need more studies, ideally randomized trials in different centers with different patient populations. But still, the conclusion here seems pretty powerful.
It is. The paper concludes that for older patients with a single small HCC, MWA was superior to surgery in terms of complications and hospital stay, and there was no significant difference in the 5-year survival outcomes. It's a strong endorsement.
So the big takeaway really is about the personalization of care. It's about moving away from a one-size-fits-all gold standard mentality and towards a more nuanced approach that weighs all the factors. Long-term survival, yes, but also the immediate burden of treatment and the quality of that survival, especially in our most vulnerable patients. It makes you wonder, how many other gold standards in medicine are just waiting to be challenged by less invasive, more patient-centered technologies? And how do we as clinicians get better at having those nuanced conversations about the trade-offs? It's a profound shift in thinking. And for the patients this paper talks about, it's a shift that could make all the difference.